So I'm going to talk in general about genetic testing, somatic and germline, kind of the when and how of it. In so many ways, I think most of us already know that genetic testing is important. It's here to stay in prostate cancer. It's not a debate anymore, and yet there's plenty of gaps in the data. There's gaps in our knowledge. Specific scenarios. What about active surveillance? How does it matter? What about low-risk disease? Should we be doing any testing at all? What is the prevalence of finding germline aberrations in different clinical scenarios? What about cell-free DNA versus tissue testing? Should we retest, et cetera? So I'm going to try to address some of these questions in these talks. I'll show you the data, where data exists. There's plenty of data gaps. But nevertheless, there are some pieces of data we can now speak to, and it's in a lot of these situations where we're talking about probabilities. I'm not going to give you an answer to say that we should or shouldn't do something. Rather, the probabilities will have to be something you ponder on your own to say, are the percentages high enough that I think I should do this or not, right? So first we'll talk about germline testing, and then we'll talk about kind of serial somatic testing. So as I said, no question, genetic testing is now part of our best practice, but the topic remains confusing. When should we talk about germline? What kind of somatic testing should we do and when? So the why is straightforward enough, right? When we talk to patients about germline testing, there's always two pieces to it. One, it can inform your own treatment, right? It can change the treatment options we have for you. Two, it can make a difference to your family. And that's why, right, for several years now, it has been a recommendation by all the various societies to get germline testing in all men with high risk, very high risk, or metastatic prostate cancer. This is consensus now, and yet we all know that this really isn't being done in real world practices. The percentages, unfortunately, are very low. But what do you do in very low risk, or intermediate disease? Certainly there's disagreement here. People would say if there's family history, if there's introductal histology, do the testing. But what's the data behind this? We're going to talk about it some. And then, of course, somatic testing, we're just talking about guiding the individual patient's therapy. We're not talking about the family, right? So this, of course, was the paper that really finally jump-started, I think, interest in the field. This is Pritchard in 2016, showing that in a case series of men with metastatic disease, the prevalence of some kind of pathogenic germline variant, right? So we talk about PGVs, somewhere on the order of 10 to 15% when you look at various data sets, maybe as high as 23, right? If you have a high-risk population, maybe somewhat lower in a low-risk population. But in general, somewhere between 10 to 15% of men will have some kind of inherited pathogenic germline variant. Now, when you look at this slide from Pritchard, one of the things that stands out, of course, is it's really not just the HRR genes, BRCA1 and 2 and others. BRCA2 is the most common pathogenically altered gene in prostate cancer patients, but there's the long list of others as well. So I think one of the first questions that comes up for the practicing physician is, what panel do I order, right? I'm ordering from whatever company you want. You get their germline panel. You can order just the BRCA test, for example. What I would say to you is recognize that when you send in that serum or epithelial cell sample on your patient, the testing company will test the entire panel of genes. It's not economical to put the sample on the analyzer and just test BRCA, right? So on every single sample you send in, they're testing the entire panel of known familial pathogenic gene variants as identified by the American Society of Human Genetics. The only difference, based on the test you order, is which ones they report back to you. Okay? So the question comes up, why would you want to only know the BRCA when they're testing all, 50-odd, 80-odd genes now, I guess it is, right? I would say order the full panel. It costs the same. There's no difference, in terms of the work that's required or risk to the patient. And you might say, fine, MSH2 doesn't matter to me as a prostate cancer physician. Well, actually it does. We've kind of seen some of that data. But even if all you do is allow the patient to get early detection of his colon cancer, or allow the patient's daughter to get early detection of her, uterine cancer, that's a win, right? You've saved a life. So why would you just choose to hide the information from yourself? Don't do it. Order the entire panel, not just the BRCA panel, right? It's the same test, okay? So we say, right, maybe 15% of men with prostate cancer carry a hereditary cancer risk gene. Now, the data I just showed you was advanced prostate cancer. BRCA2 the most common, followed by ATM and BRCA1. Remember, BRCA2 is also associated with breast cancer, pancreas, and ovarian. So we often talk about BRCA, certainly in the community, as the breast and ovarian cancer gene. People forget it's prostate and pancreas. There is no familial pathogenic gene variant that is gender specific, right? You can cause different cancers in men and women, but every pathogenic variant carries risk for both genders. So there's no reason to limit a family history or a discussion about genetics based upon gender, right? It should always cross, men and women alike without any question. Lynch syndrome, for we in the urology community, not to be forgotten, but I think it often is. Don't forget, upper tract urothelial cancer is part of the Lynch syndrome family of diseases. I would bet that, not more than a couple of % of all your upper tract urothelial patients are actually getting tested for their germline. But they should, because they could have Lynch syndrome, maybe 10% or so. And of course, if they have that, then again, there's implications for their family as well as for their own screening, right? So something that ought to be tested. This is not a urothelial cancer meeting, but we're all in the GU space, right? Okay, so remember, you're not just testing to help the patient, though. You're also testing for their family. And I think we're past the point where I have to argue this point anymore, but for years we still had to. Doctors would say, oh, I'm busy in clinic, I don't want to have the conversation, I'm worried about the legal risk of counseling, I don't know what to do with the result. But if you've done this long enough, sooner or later, you're going to have that patient that comes into your clinic, right? You're going to have that 70-year-old guy, you operated on his Gleason 8 10 years ago, he's done well. And he comes into you and he says, hey, doc, my daughter with the 2 kids, she's 35, and she just got diagnosed with metastatic breast cancer, and you know what? She's BRCA positive, and so am I. Why didn't you test me, right? And then you're going to have to say to yourself, well, why didn't I test him? I should have. He had Gleason 9 disease. Guidelines said I should have tested him. And maybe you could have saved your life and prevented the kids from losing their mom, but you didn't, right? So every man with high-risk disease has to be tested. You should be having that conversation with 100% of your gentlemen, not 90%, not 50%. You should audit your own practice and see if you're doing it or not. In my notes, I have an advantage, I'm in advanced prostate cancer, right? But that's part of my standard note template. I have a line that says genetic testing, and I say there whether I've had the conversation or not, and whether I've had the test or not. So every time a patient comes in, the line is right there in front of me, and I can't possibly miss the fact that I had the conversation or not. If the man says no, that's okay, you did your part. But at least make sure you're having the conversation, right? All right. So then the conversation comes up, why don't I just do the family history, forget about the clinical. If the family history is negative, I don't have to test. So this is an important data set. This has been repeated in multiple cancers now, so this is consistent across malignancies. We've seen it in breast cancer, we've seen it in kidney cancer and others. What this looked at is over 1,100 men with localized prostate cancer who had germline testing. And they said, how many of these men were positive for a pathogenic variant, and how many of them would have met the old family history criteria for whether they should have been tested or not. And what you see here is that almost 40% of patients, 36.7% of patients, would not have met the family history criteria to justify testing, right? So the question is, does family history qualify as a good screening tool to tell you who should get germline testing or not? No, it doesn't. If you rely only on family history, you're going to miss, over 35% of the men who are carrying a pathogenic variant. And, this is because the family history data was based upon that era where, everyone had 10 kids, right? When you have 9 siblings and so do your parents, family history works really well, right? There's the penetrance issue. Does cancer develop or not? But in this era where, the median family is 2 children or less, people are orphans, maybe their one sibling just died at a young age, right, at 40 in a car accident. Family history doesn't work in those settings. So I would tell you definitively, don't rely on the family history to decide who should be tested or not, right? You need to do the individual history. I thought Dr. Carlson's comment and coming from Dr. Delfand of saying, quantitative family history is a really important way of thinking about this. We have to go beyond just, the family history criteria. I think that's an old way to practice. Okay, so here's, a summary of current guidelines for germline testing. It's a mess, right? You can't go and look at this every time. There's all these different guidelines, if this, then that. You can't possibly memorize all this, right? You can put this in your clinic if you want, but again, I think it's too difficult. I think we need to simplify, right? So the very simplistic way I would boil this down, high risk, very high risk, metastatic, we should test all patients regardless of family history. Really simple, right? You don't have to go further than just saying you have high risk disease, you must be tested. Low and intermediate risk, this is where, there's a bit more disagreement, and in the subsequent slides, I'll show you some data that you can think about. So lower intermediate risk, it's recommended if you have personal or family history of prostate cancer, personal history of breast cancer, of course, in men. You may be considered for high-risk histology, or if you have one of these other malignancies. That's a bit of a summary from these various, guidelines. But does that data hold up? So I thought this was a fantastic study by Neil Shore and colleagues. And what they looked at, similar to the previous study where I was saying, does family history accurately predict? Now they're asking the question in the PROCLAIM trial, does NCCN guideline criteria really help you identify who's at high risk of having a pathogenic germline variant or not? So very simple design, right? They took all men with newly diagnosed prostate cancer, and they first say, does that patient meet NCCN criteria for germline testing or not, yes or no, defining an in-criteria group and an out-of-criteria group, right? So this is almost 1,000 patients included in this study. And then they look at, are there pathogenic germline variants? Over 80% of patients had localized disease. Almost 2/3 had low or intermediate risk prostate cancer. Okay, so in the middle column, you say all 958 patients, half of patients were in criteria by NCCN guidelines, half of patients roughly were not. You can see the localized disease prevalence, of course, heavily weighted towards the out-of-criteria group, right? So the localized disease patients who were in criteria are going to be your high risk, your very high risk, or abnormal histology, or family history. And then in that bar chart on the bottom, you see what is the rate of pathogenic germline variants for the in criteria and out of criteria group. And what you see is it's not very different, right? It's not very different. So what this is saying is that the NCCN criteria don't really discriminate who is likely or not to carry a pathogenic germline variant. Now, this doesn't mean you should or shouldn't use the criteria, right? I mean, they're setting aside payer considerations, but what it means is, that you have to ask yourself, sorry, how do I go back here? What did I do wrong? I got it. There we go. You have to ask yourself, right, if the likelihood of finding a pathogenic germline variant in the out-of-criteria group are just about as high as the in-criteria group, should you be thinking about testing the out-of-criteria? Is a 2.2% difference enough? I don't know. I don't know the answer. Again, this is where, we're looking at probabilities, and you got to apply some clinical judgment and say, who should I be testing? But statistically speaking, right, there's no significant difference between the patients who meet NCCN criteria or not for their likelihood of being a carrier, right, of a pathogenic germline variant. That's a debate. I think, Dr. Carlson could get much more sophisticated about this than I could, right, in thinking about statistics and what we should do with this, right? All right. And then what about in the low or intermediate risk patient? Well, all right, fine. You can find the germline variant, but does it predict for lethal disease or not? So I thought this was a fantastic study by Dr. Darst and colleagues, Dr. Darst of USC, now at University of Washington. And this is an analysis across 18 different international studies, European ancestry, right? So recognizing, right, this just deals with a cohort of our patients, not all patients. But this was looking at the frequency, the carrier frequency of pathogenic variants between men with aggressive and non-aggressive prostate cancer who then moved on to metastatic or lethal disease or not. Okay, so they had over almost 700 men with low-risk prostate cancer who later progressed to metastatic or lethal disease, and they had over 4,000 men with low-risk prostate cancer who did not progress. Then they looked at, is there a difference in whether or not they carried a deleterious pathogenic variant? And the answer is indeed there is, right? So looking at 11 candidate genes, the men who were carriers of pathogenic variants in those genes, and this is largely the HRR genes, had a twofold increased risk of lethal disease. So even in lower intermediate risk prostate cancer, having a pathogenic germline variant does predict for poor outcomes. So it is relevant, right? Now, again, this is probabilities, and so you might say to yourself, right, should I use that? The result is largely driven by BRCA2, ATM, and NIBIN, right? BRCA2 being the vast majority of the cases. This is not a surprise. And this is something you'll see time and again in all of the PARP inhibitor studies, and all the studies of how BRCA and other gene aberrations affect outcomes in men with advanced prostate cancer. BRCA2 is bad. It's not just predictive of response to PARP or other drugs, it's also prognostic. These men do worse no matter what you do with them than compared to men without the BRCA2 aberrations, right? So even in lower intermediate risk, having one of these aberrations denotes more aggressive disease. The patients are more likely to die. Now, how we weight that in our decision making, I don't have the answer for, but we're starting to see, right, consistent patterns that these things matter to your individual patient, even when you're not going to be treating them with a PARP inhibitor or otherwise. But what about active surveillance? I think this is a common question that comes up. Can you do active surveillance safely in a man who has a pathogenic germline variant? If you've tested him for whatever reason, or maybe he comes in knowing, maybe he's being screened because he knows he's a BRCA carrier. If you find it, is active surveillance a legitimate option or not? So here's one data set, fairly small. You can see it's not a large number of patients. And we're going to look at a second data set after this. Asking the question, will you see progression? Are you more likely to see progression if you have a germline carrier, right, at confirmatory biopsy or radical prostatectomy? And what they say here is only 20% of these patients in their data set had upgrading at confirmatory biopsy. 80% of patients remain on active surveillance free from upgrading or radical treatment. So, okay, right, that's some reassurance that maybe you can do active surveillance in these patients. Here's a second data set. Again, fairly small numbers of patients, prevalence being what it is, right? But this is from the Hopkins and the North Shore group. They combine their data, so you get over 1,000 patients here. In that, 98 patients in their active surveillance cohort were eventually upgraded on confirmatory biopsy. Of the patients who were upgraded or not, you see the prevalence of BRCA1, 2, and ATM pathogenic variants. And what falls out in this data set is the BRCA2 patients are more likely to have progression and be upgraded than patients without the aberrations. It's just me walking on the stage here is causing slides to move. But BRCA1 and ATM, at least in this data set, small numbers, right, don't fall out as statistically significant for predicting likelihood of upgrade. And now you see this broken down, 2 columns here, upgrade to any level and upgrade to greater than or equal to grade group 3, right? So the really clinically significant ones. And here again, I mean, you see in both cases, right, the mutation carriers are more likely to progress. Doesn't mean that active surveillance was the wrong answer, right? But it just emphasizes, yes, you're more likely to see progression, and it's important to be rigorous, right, about getting the confirmatory biopsies, and following these patients. All right, so just a summary here of the germline piece of the talk, right? So without question, guidelines, we should have testing in all men with high risk, very high risk, or metastatic disease, without question. But here's the thing, is that the prevalence of pathogenic germline variants is actually fairly consistent across risk groups. So the rationale behind who we're testing is not based upon the likelihood of finding a positive result or not. It's not based on that, right? It's just based upon how justified do we feel in adding yet another test on to the patient's, to the patient's workup, with the implications that that might have for the patient. So I think that's the way to approach the conversation with the patient, right? You're just as likely to have a pathogenic variant as any other prostate cancer patient. For the low-risk patient, you might say, look, there's a bit more space for you to kind of individualize how you want to do things. It's not an absolute recommendation, but it's something to think about, because it's not accurate to say that if you have low-risk disease, the chance of finding a familial gene syndrome here is very low. That's simply not accurate, right? The likelihood is just as high as in the high-risk patients. And it is prognostic. It's not just predictive of response, it's prognostic of progression and of aggressive disease and lethality. All right, so somatic testing. I'm going to go into a case study. This is a patient of mine. Some of you may have seen this before. This gentleman was first diagnosed at a young age, at 57, Gleason 3+3 disease. A year later, PSA is going up. So, he did active surveillance first. Now PSA is going up. He elects for treatment. Now, unfortunately, he's node positive. So he goes on adjuvant ADT to start. Off the adjuvant ADT, he has PSA recurrence, no metastatic disease, so he has salvage radiation therapy. This only works, unfortunately, for a short time before he's really having now substantial PSA progression, and now he has imaging progression with retroperitoneal lymphadenopathy. He was on ADT at the time, so this is castration resistant. He does CYP-T. He goes on abiraterone. We do germline testing at this point. There's no pathogenic variants. We test the tissue from the prostatectomy tissue, which at this point is 4 years old. And you don't see much there, right? Low tumor mutational burden, MSI stable, not much to say about the KMT2D mutation. All right, so he's on abiraterone. After a couple of years, he starts to progress again. Now he has low volume bone metastases. We switch him to docetaxel because, of course, we don't switch from one ARPI to another, right? Although mostly we do, and we shouldn't. But we put him on docetaxel. He does well after 8 cycles of chemo. He has stable disease. He's still responding. We stopped chemo, and then eventually he progresses now, rapid rise in PSA, and perhaps progression of his bone metastases. So at this point, I don't have soft tissue disease to biopsy, so I get cell-free DNA testing, and I find a BRCA2 aberration. This is a pathogenic aberration in BRCA2 that we did not see on the prostatectomy tissue. So what does that mean, right? Because we have these conversations. We say BRCA2 aberrations are truncal. They should be there from the beginning. They should not develop later. Why did we retest at all? Is this just a passenger mutation? Is it a driver? If it's just a passenger, we shouldn't target it, right? We don't know the answer to that, so I put him on rucaparib at the time. And here you can see his PSA pattern. So I start him on a PARP inhibitor. Not unusual, as with many drugs, we'll see an initial PSA progression. We don't worry about that. It happens quite often. But here you go. This man stayed on a year of therapy. His PSA improved from over 50% from peak before he started to progress again. No radiographic progression throughout this course until a year later he has clinical progression. So what this says to me, right, is you could debate all you want. Was it a passenger? Was it a driver? It was clearly a driver. The patient responded to a PARP inhibitor. And there's no reason otherwise that a PARP inhibitor should have worked for him, right? But then it really creates a problem with the whole argument of saying, no, these are early events. You only have to test once. Why did this show up later, right? So why indeed? And I think there is some data that can help us think through this. So now I always say, right, as a medical oncologist, I always go back to this. Nothing in biology makes sense except in the light of evolution. So every conversation we have about disease, about treatment sequencing, every conversation we have about what treatment to select, how to select them, how do we think about how to approach a cancer, what we're doing in the oncology clinic is we are inducing natural selection on an ecosystem, right? And the cancer evolves based upon that natural selection. This is pure Darwinian evolution. There's nothing new about this, right? This was described centuries ago. So if we think about the cancer as an organism, as a population, right? When we talk about clonality, we're just talking about, multiple different, animals of the same species. You come in, you apply your pesticide, most of the locusts die, but some don't, and the ones that survive are the ones that are resistant, right? Now you have a hardier species. The same thing is happening with our cancer, whether it's prostate cancer or anything else. So this is why I actually retest. And some of you may have heard me say this before. In a more innocent age, it was okay to say that I approach somatic testing like voting in Chicago early and often. Nowadays, we can't quite say that anymore, but still, that's the same concept, right? I retest because cancer is a living organism that evolves over time. So if I'm going to make a treatment decision based upon testing, I want to know what the cancer is today, not what it was 5 years ago, because it is a different organism today than it was before. But there's also the fact that tests can be wrong or incomplete, okay? The test you got before is not 100% accurate, and I'm going to show you that. But there's also the fact that knowledge is expanding daily. So all the testing companies will constantly update their databases as knowledge comes out. They will supposedly, right, reissue a report, get it to you. I mean, they will do that. Occasionally you'll get these reports. But we all know what happens with reports that get faxed in and whatnot. You might get them, you might not. The patient's moved, maybe you get it, and their doctor who's treating them doesn't, right? So I retest. One of the data pieces to talk about tumor evolution, this is an old study now. This came out of the Memorial Group, Wasim Abida and colleagues. And this is just different patients, not patients over time. This is not the same patient going across. But this is looking at their population of patients with local regional disease, with metastatic hormone-sensitive disease, and metastatic castration-resistant. And what are the genomic profiles of these different patients? And no surprise, right? What you see is that as the patient progresses, as you get more advanced disease, you get more aberrations. It's a cumulative process, right? Much like Dr. Boswick's data kind of showing, right, as that branching evolution of disease, it is cumulative. And so all the aberrations you see in localized disease are more common in advanced disease, and the more advanced we get, the more aberrant the cancer gets. So if you test only the prostatectomy sample, right, you're going to get a snapshot of a much more benign disease process than what you get when you test metastatic disease. Another important data piece, we talk about cell-free DNA testing, we talk about tissue testing, but the question that's going to come up is the cell-free DNA testing accurate? Does it actually reflect what's going on in the tissue? The only way we can answer that question is from these data sets that give us simultaneous testing of both cell-free DNA and tissue. And what you see here in the column to the right is vastly different results of the percent agreement between the two different tests. And I'm going to tell you what this reflects is the inaccuracy of both tests, but also the age of the tissue that's being used. Okay, this issue I was talking about of what is the disease today versus what it was, but more importantly, the issue of what happens to tissue over time, stored in formalin, right, in a freezer somewhere, or in a storage unit somewhere. And the fact of the matter is, the DNA degrades, and your likelihood of getting a positive result goes down. And this is a real problem. So this study by Maha Hussein and colleagues, I think is as much data as we need to really answer this question. They looked at nearly 5,000 samples from Foundation Medicine, over 4,000 patients, and they analyzed all the samples, of which 83% were primary tumors, 17% were metastatic, and they looked at the age of the tissues, newly obtained versus archival, right? They show you here, number one, just based upon archival versus recently obtained, what is the likelihood that you'll get a positive result at all? And no surprise, the newer the tissue, the fresher it is, the more likely you are to get a positive result. The older the tissue, the more likely you are to get a negative result. So what this is, right, quite possibly is a false negative, right? It's simply the tissue is old, the test didn't detect something. Now, does that hold up? So then they broke it down further, and they looked at all the archival tissue based on age, right, less than 1 year old versus greater than 10 years old. What is the likelihood that you find a positive result? And what you see here, right, is with every year you go by, the likelihood of getting a false negative goes up. The likelihood of getting a positive goes down, right? So tissue degrades. And what I would say to you, I mean, at the end of the day, as you look at this, right, here's the 5-year mark. I think if you're drawing archival tissue that's more than 5 years old, right, you've only got a 50-50 shot of actually getting a positive result. You've lost, from 68 to 50%. You've lost a fifth of all the positive results. You're getting a lot of false negatives. And this is why I don't think we should use archival tissue. This is why I think my patient in that case report, the BRCA2 aberration that I didn't see in the prostatectomy tissue, it's not that it wasn't there, it's just that the tissue was old, right? And so it was a false negative. Because I do think that BRCA2 aberrations are truncal. They happen early in the disease course. I just think that the prostatectomy testing was wrong, okay? I can't prove that, but that's my belief. All right. And then the other piece is cellularity, right? So as Dr. Bostwick was talking about, in prostate cancer, we generally don't get sheets of cells. It's not like kidney cancer. So you can get highly variable amounts of testable DNA in a given sample that's sent for testing. And what this table shows from the same study is based upon age and the amount of DNA extracted, what is your likelihood of getting a positive result? And no surprise, right, when you have less DNA, you're more likely to get a negative result. When you have older tissue, you're more likely to get a negative result, right? So it's another thing to think about. Are you getting a false negative just because the sample you have, the only sample you have available, just doesn't have a lot of tumor content? All right, and then there's the other piece, right? As I said, knowledge changes over time. So what we would have said 10 years ago about what are targetable aberrations is very different from what we might say today. And so this was just a snapshot at a moment in time, it's actually over a year ago now, about, hey, here's some ongoing studies looking at gene targets, SPOP, RB, P10. These are things that are not currently FDA approved, but they are in trials. Right? And 5 years ago, there was nothing for BRCA1 or 2, but now there is. In the coming years, we might have positive data for these alterations. And if you just go back, right, if you say, well, I'm just going to look at the Foundation report I got on my patient 4 years ago, right, and rely on it, I mean, it gives you accurate information for what was known, right, 4 years ago, but it's not necessarily going to be accurate for all the options available for your patient today, right? And if you feel comfortable enough that, right, you know everything that's approved and you don't need the guidance from the NGS company, that's okay, but I think a lot of us, right, it's useful to get the input from the testing company as well. All right, so somatic testing, without question, test every patient with metastatic prostate cancer. When testing for tumor mutations, you want to know what the tumor looks like today, so my bias is always use a fresh biopsy whenever possible. That's our gold standard, because archival tissue is often degraded and tumors evolve over time. When tumor tissue is not available, go ahead and get serum testing for cell-free DNA. And my bias, as I say, is to retest before each new line of systemic therapy, since the tumor can gain new mutations and because testing can be inaccurate, right? And that's it.